we know you're not there.
Is there a way to make this go away? Probably not. All right, I am Julia Mastracci, and I'm going to be talking about mental health and orthopedics, the impact and management. I have no disclosures. This is a brief outline. We will start with a case example. PG, this is a 57-year-old female who has a past medical history of diabetes, Charcot-arthropathy. She previously had a left foot Charcot reconstruction in 2017 and then subsequently re-presented to our clinic in August of this year with infected hardware and osteomyelitis. She underwent a hardware removal, at which point she was admitted to the hospital afterwards for 16 days. During this time, it was documented that she was clear to discharge home, that she was able to transfer safely from her wheelchair to the bed, but that she insisted on being placed in a skilled nursing facility, which caused her to stay admitted for 16 days. During this time period, she was threatening to sue team members, quote, because her toes were bumped. She eventually was discharged, and soon after she began calling the clinic, demanding to have the cast that was put on removed. She hung up on medical assistance. She eventually did have this cast changed to a walking boot that was clearly documented against medical advice. She subsequently developed an ulcer on her foot and then refused to send pictures of this ulcer via MyChart or email. She was demanding to send these pictures to a medical assistant's personal cell phone. When this was declined, she cursed over the phone and hung up the phone. So an outline on mental health. The NIH estimates that 1 in 5 US adults lives with a mental illness. We know that mental illnesses are undertreated by non-mental health care providers, such as orthopedic surgeons. It is the leading cause of disability in the United States, and the prevalence in the US population for different mental illnesses include 19% anxiety, 10% personality disorder, and 8% with a major depressive episode in the past year. Moving on to mental illness and orthopedics, we know that it contributes to higher rates of pain. This paper published in Foot and Ankle International in 2014 looked at 45 patients in the UK with chronic foot and ankle pain that was defined as greater than 6 months in time, and they were matched with 45 controls. They completed questionnaires, including the hospital anxiety depression questionnaire, as well as a personality questionnaire that assessed extroversion, neuroticism, and psychoticism. And they found that patients with chronic foot and ankle pain had higher scores of depression, anxiety, as well as neuroticism. Neuroticism is part of the big 5 personalities. Us residents actually took this test and got scored on our neuroticism percentages. But the big 5 personalities are openness, conscientiousness, extroversion, agreeableness, and neuroticism. Neuroticism describes an individual's response to stress, but it is not a mental health diagnosis in itself. Highly neurotic patients have higher rates of anxiety, depression, mood disorders, substance use disorders, eating disorders, as well as somatic symptom disorders where they hyper-focus on any one physical symptom. This paper, published in JBJS in 2016, looked at 169 patients with symptomatic full-thickness rotator cuff tears diagnosed on an MRI. They completed questionnaires including the visual analog pain and shoulder function test, the SF-36 quality of life score, the simple shoulder test, as well as the American Shoulder and Elbow Surgeon score for pain and function. And they found that the SF-36 had a stronger association than rotator cuff tear size for all 4 pain and function categories. We also know that mental illness contributes to higher post-op pain as well as higher narcotic use. This paper, published in 2016, was a retrospective chart review of 139 patients who underwent major ankle or hindfoot reconstruction with a minimum of 2-year follow-up. They looked at patients with mood disorders that were defined as depression, schizophrenia, and bipolar disorder, and they found that patients with these mood disorders had higher rates of both narcotic use and pain at the 1-year post-op period. We know that mental illness contributes to worse patient-reported outcomes. This paper, published in JBJS in 2021, was a single-center retrospective analysis that looked at patients who underwent total ankle arthroplasties. They had 612 patients with either 1 or 2-year outcomes. They completed questionnaires, including, again, the SF-36 mental component summary, the SF-36 physical component summary, the short musculoskeletal function assessment, and the visual analog pain scale. They found that patients with depression had less improvement in their SF-36 physical component summary, as well as less improvement in their VAS pain scores. And they also found that patients with depression, as well as patients with a low pre-op SF-36 mental component summary, had worse final outcomes. And finally, we know that mental illness contributes to higher complication rates. This paper, published in JBJS in 2016, looked at 332 orthopedic polytrauma patients and their prevalence of psychiatric illness. They found that 39% of these patients had a psychiatric illness, with 22% having depression, 17% having substance use disorder, and 5% having anxiety. And that depression was an independent predictor of complication with an odds ratio of 2.9. And complications included AKI, sepsis, DVTs, infection, as well as pulmonary complications. And then finally, out of the arthroplasty literature, this paper, published in 2018, queried a national database that identified all patients who underwent a total hip as well as a total knee arthroplasty. They identified roughly 505,000 patients, 953 of which had schizophrenia, and they matched these patients in demographics as well as comorbid conditions. They found that patients with schizophrenia had higher rates of medical complications, including pulmonary complications, altered mental status, and blood transfusions, as well as higher rates of surgical complications, including clinical complication of the implant. These patients with schizophrenia were more likely to discharge to a facility and had a longer length of stay. And this slide is just to demonstrate that these trends and this literature can be found throughout all of the orthopedic subspecialties. It's kind of beyond the scope of this talk to go through all the literature, but similar studies and trends exist for spine, hand, pediatrics, as well as orthopedic oncology. So moving on to what we can do to help our patients. First, we can address in-hospital management. I'm not going to go into great detail about this. We heard a grand rounds from Dr. Shu regarding opioid use a couple of weeks ago. And we know that anxiety levels correlate with pain in the post-op period. We have a great tool, the opioid sparing pain management plan, that we can utilize to manage anxiety and therefore manage pain in the acute post-op phase. And these tools include animal therapy, music therapy, aromatherapy, and meditation. We can help by screening patients in our clinic. We know that there are barriers to screening. This paper surveyed 350 orthopedic surgeons on the degree to which the surgeons noticed, assessed, and screened psychiatric illness, as well as barriers to engaging in the screening process. These orthopedic surgeons noted that the greatest barriers for them were time limitations, discomfort, and unfamiliarity with the issues, the stigma surrounding mental health, and not wanting to upset their patients. This is out of the primary care literature. It was published in the Journal of Clinical Psychiatry in 2003, and they utilized the electronic medical record to help screen for depression. In one practice, they utilized the epidemiological studies for depression scale, and they screened all of their patients. And these results were communicated directly to the PCP through the electronic medical record. They ultimately screened 1,000 patients over the course of a year, 22% of which screened positive for depression. 35% of these depression diagnoses were a new diagnosis, 31% were prescribed new psychiatric medications, and 46% had a change in psychiatric medication. And this is a case report out of UCLA. There's no specific piece of literature or paper that encompasses this, but it's highly advertised on the EPIC website. So basically EPIC and UCLA teamed up through their primary care department and utilized a tool to screen for depression as well. So they had their medical assistants verbally perform the PHQ-2 depression screening test, which is a 2-question test. And if the patient answered either of these questions positively, the patients then performed the PHQ-9, which is a slightly longer questionnaire electronically. And these electronic responses were updated or automatically auto-populated into the electronic medical record. Depression screening rates increased from 16 to 74%, And they noted higher rates of new depression diagnoses and higher rates of psychiatry and psychology referrals. We can help our patients by managing their expectations and providing information and resources to them. This paper that was published in 2021 was out of England, and they looked at 26 patients who had sustained open tibia fractures, and they conducted semi-structured interviews. And the patients noted that the biggest stressor for them was uncertainty if they would fully recover. So we can help our patients and lessen their stress by clearly outlining our expectations for them as well as our goals. And this includes providing resources to them, both physical and online resources that outline their expected recovery. And we can also help our patients by providing feedback regarding their progress. We can help our patients by identifying coping strategies. The same study published out of the UK that was looking at open tibia fractures identified that task-oriented coping strategies helped patients cope better. And the more specific the task, the better. And this includes specific mobility goals, specific diet goals, health goals, as well as well-being goals or tasks. We can help our patients by referring them to support groups. It is known that group support is a beneficial coping tool for orthopedic trauma survivors, that it results in stress reduction, and that it aids in the transition from hospital to home. Examples of where I think we're already doing this well is in the Ortho Carolina Amputee Clinic, where patients can just naturally gather and talk with each other, as well as through the Trauma Survivors Network at Atrium. And then finally, we can refer our patients to a primary care provider or to a mental health specialist. This same study that we talked about earlier that interviewed 350 orthopedic surgeons found that we have a low likelihood to refer these patients who we think have mental illness to a PCP or to a specialist. 75% of orthopedic surgeons stated that they were very likely to notice psychosocial contributors to a patient's well-being, but only 27% were very likely to refer these patients to receive psychological treatment. And we know that primary care physicians are managing mental health at an increasing rate. From 1995 to 2010, rates of visits to a PCP for mental health increased significantly faster than rates of visits to a psychiatrist for mental health. From 2012 to 2014, mental health office visits were managed 55% by psychiatrists and 32% by primary care physicians. And in 2010, 100% of primary care physicians prescribed antidepressants, 91% prescribed anti-anxiety medications, 41% prescribed antipsychotics, and 36% prescribed mood stabilizers. I think it's important to note that there are barriers to accessing mental health care, and we need to keep this in mind when we're referring to mental health specialists. It may be a reason to refer to a PCP rather than to a mental health specialist. There are shortages in mental health providers, and there's also can be a large financial burden associated with mental health providers. So in conclusion, we know that mental health in orthopedics is prevalent and it contributes to chronic pain, higher narcotic use, worse patient outcomes, and higher post-op complications. And we can help our patients with in-hospital anxiety and pain management. We can utilize screening tools, possibly through our electronic medical record. We can manage our patients' expectations as well as provide information and resources. We can help patients identify coping strategies that may help them identify support groups and consider referring back to their primary care physician as well as a mental health specialist. These are my references. Thank you to Dr. Sean for being a great mentor in this talk, as well as Dr. Irwin and Dr. Ford for providing feedback on this talk.
Good. Congrats to you and Catherine for actually pairing these two together. So much overlap between talks. So we all know there's no lack of studies in orthopedics in every subspecialty, as you mentioned a couple of them, that demonstrates worse outcomes when your patient is compromised by some of these other diagnoses, depression, other psychological issues. So the question is, how do we walk the line? And in reading this, did you see anything about this in terms of patient selection? Because you could sit there in your clinic and screen somebody and say, you have higher psychological issues, depression, whatever it is, you will have a worse outcome, so I'm not going to operate on it. And in the days of this bundled care episodes where we know that there's higher complications, higher issues around, there be higher costs to take care of with poor outcomes, you can make your practice look bad, but then why would people want to disclose anything? Why would somebody want to even take a test if they knew that there was, in a way, rationing of care based on their underlying diagnoses? How do we deal with that?
Yeah.
Easy question for you.
Yeah, easy question. I think that's one of the biggest kind of not troubles, but tricky things about this is when we know that patients, especially patients that may undergo elective surgeries, have some sort of mental health contributor. What do we do? And I mean, I don't think there's any great solution or great answer. I do think that perhaps we should refer back to primary care providers, kind of like we get clearance, like medical doctor clearance. Like, I don't know if we necessarily need like mental health clearance, but maybe we need to get these aspects of a patient's care optimized before we do elective surgery.
About 7 or 8 years ago, when optimization thing came to the forefront, screening for malnutrition, screening for obesity, smoking, and we thought we just one idea to add a PHQ-9 in, a depression scale to screen for these patients. Screen added in a couple of patients, and what we found, we had we saw some of the suicidal reports that very severe depression and some. We found is that the vast majority of people who scored high on the depression scale did it 1 year later, and 80 or 90% of those were not depressed anymore. So orthopedic elective problems, like chronic pain in your hip, your knee, in our case, curing depression by arthroplasty, basically.
It's magic.
So we took depression out of the optimizations. First of all,
So, I think that I agree with Dr. Perry. I think there's some good literature showing that these correlate together in pain and limitations in activity. In the atrium system, we built out the PHQ-2 feeding into the PHQ-9, and actually part of our CDC funded work right now around opioids builds that into the acute care setting. So in the emergency department as well as inpatient space, we'll be moving all of that to Epic. There's also a robust effort from the behavioral health integration into primary care clinics and feeding into the care setting. Eric Sequist and Dr. Lally are currently finalizing a paper for acceptance around the implementation of that into Dr. Chu's orthopedic. So having a system that is embedded into the workflow where we can to get them directly to the care that they might need. Not everybody needs treatment, right, for mental health, but even identifying some of the problems and being aware of it is the important thing. For treatment, management, and there's a lot of kind of treating depression with weights and that. So I think there are some great tools that we'll be looking at how those play out.
I think kind of tagging onto that and your comments about Epic. So it's very easy to do this. So in outpatient pediatrics, I can tell you, every patient that comes in gets an anxiety and depression screen. And it's a quick little screen, and then they get referred to the next step, and do they need an external active management. It's just embedded in their workflow. And some of these things we complain about all the things we don't like about the electronic health record, but there are some positives in the way that you can sort of embed things into a workflow. I think that that's available for really everybody. Their parent doesn't need to screen anymore to figure it out, but it's something. I think there's also a lot we can probably learn from our, but I think one other sort of lesson from what you showed is that we probably have a lot that we can learn from the trauma side, which is the non-elective side. These people don't choose where they are. We clearly can't delay a femur fixation because somebody has a positive depression screening. So I think that a lot of these interventions that we sort of look at and support we can provide people in the trauma setting, maybe things just like we talked about navigation in the social determinants of health realm, should this be stuff that we are better supporting folks in this non-elective situation, or can we do it in the elective situation better?
Yeah.
So much too. It's not just the screening part of this. Is working on it. This is not just the matrix issues and action issues. So we're working on all of these ways to better identify. But our primary care physicians are already working their butts off.
Mm-hmm.
As you noted too in your talk, we're at a shortage across the country. So I think these types of talks are well, although we're not necessarily well trained in a lot of these areas. We've got to take an active role in this. Because screening will identify more issues across the system right now is not built. Probably.
Yeah, I agree.
Any other comments? Anybody online have any comments?
Yeah, I wouldn't mind jumping in. So there's really good talk, Julia.
Hold on. We can't hear you.
Can't hear me?
No, I can hear you on my phone.
Oh, I'm not on mute.
All right, I'll hear you really great.
Can you hear me now?
Yeah.
Yeah. Really good talk. A lot of the focus on screening, and I could hear Dr. Seymour as well talking about some of the stuff that we built in. One of the things I'll tell you in the outpatient setting is that there is an opportunity to intervene directly, and we as orthopedic surgeons can do this. And you don't really have to just say, hey, we're going to refer, because as Eric Seacrest's paper will show, that even a lot of people you refer don't follow up. So there's a couple interventions that we can do directly. Number one is we actually have a patient-facing handout that has some resources for anxiety and depression management. And as you discussed, Julia, that those things can actually work for people. And Jenna actually made that handout, so kudos to her for doing that, and it's available for anyone to use in their clinics. The other thing is that you can start a patient on an SSRI and SNRI. We can do that. We're doctors, we can prescribe those medications. One of the things, and I've been doing it for years, one of the things that helps is if there's a bridge to their primary care that will help ensure and call them in a couple of days to make sure that they're safe. And so we did this with behavioral health telehealth, who we do an electronic referral when we screen positive the patient, offer them an SSRI and SNRI, go ahead and start them on that right away. And then they get a follow-up telehealth visit within the next 2 to 3 days after they start the medication. And then that's bridged to their primary care. As the discussion has had, a lot of these people don't even have primary care, and so that kind of becomes part of the role. It is doable, and thanks to the clinic staff, they do most of the heavy lifting on this work. And those of you who floated through my clinic have probably written some of these prescriptions as well. And so it is very doable. The real challenge has been actually turnover in clinic staff. And so the screening kind of goes up and down depending on that, but it's very sustainable.
Thanks, Joe.
Thanks, Dr. Shu.
All right, I want to mute my phone so I don't get any feedback, but thank you, Dr. Lee, Dr. Mastracci, great set of talk